Go. Can y'all see that?
Nope.
Yes, it's working. No?
No, we're seeing your calendar.
Oh, for crying out loud, really? All right.
It worked before.
It's a very
No,
nice
it's-
calendar.
It's a very, yeah, but my artwork. Why isn't this working? Let's see.
Do we lose Val? Did she go off though?
It did disappear.
Oh no.
I'm looking at the squares and I think we're one
I
down.
know I'm hearing something and I'm like, wait a minute, where did Val go? All right, so we'll give her a
Probably
minute.
logging back on.
Yeah. So while she's logging back on, I can let you know that, oh, here she comes. The title is Stress, Trauma, and Psychosis, the Terrible Trifecta. So there she is.
Oh, you're muted.
You gotta let me share.
Oh, okay.
Okay, hold on a second here. There you go.
Let's see if it works this time. Anything?
There it is. Yep.
There it is. Wow,
That's
I
the one.
don't know what happened. Okay, so welcome to Stress, Trauma, and Psychosis, the Terrible Trifecta. All right. So I'm gonna, because we only have 15 minutes, I'll skip through these little things, but you will have the opportunity to read them. They're just fun little quotes that I picked up. Please know that this 15-minute didactic doesn't prepare you to treat trauma, quote unquote. This presentation is not enough. So stay tuned for continued training. So is trauma and psychosis related? The answer is absolutely yes, beyond a shadow of a doubt. You know, even the first episode of psychosis can be considered trauma. So 80% of FEP clients with this one study that we have here by Terrier found that 80% of people diagnosed with schizophrenia, a first episode schizophrenia, actually felt traumatized by the treatment that they received. 37% felt like they actually had been harmed enough to have ongoing symptoms. 40%, that's like getting close to half, reported suicidal ideation. And then 31% found reported attempting suicide. Those are astounding statistics that bother me an awful lot, in that we may not, my cursor is problematic now. This is not going to let me do this. There we go. Okay. And CBT has shown, you know, great effects from for post-traumatic stress due to psychosis. I think we all know what the definition of trauma is. When some event or situation external to us causes us some harm, physically, emotionally, mentally, certainly sexually. We're all familiar with that. We are all familiar with the components of trauma. This is a nice little slide, though, to show you how multidimensional this concept is of trauma. So in working with it, you can see how experience is very much needed. Childhood abuse and PTSD are common in those struggling with psychosis, 4 to 20%. Some studies found as high as 46, even 50%. However, when we have people with a diagnosis of schizophrenia and post-traumatic stress, over 90% of that post-traumatic stress is completely missed. So treatment is never offered. Did I miss some stuff at the bottom of that? And yes, this is important stuff. Oftentimes as clinicians, we fear that if we start working with that trauma, it'll exacerbate the symptoms. And research shows that that's generally not the case at all. In fact, it's really pretty opposite. When studying best treatments, chronic psychosis is often the most applied exclusion criteria in treating PTSD as well. However, prolonged exposure, that's probably not great, but EMDR is actually okay. People with schizophrenia or that psychosis condition can tolerate prolonged exposure, but it just needs to be done very carefully. And EMDR is helpful, although there needs to be some tweaks in it. And so if you do EMDR, please look up protocols for working with trauma and psychosis. What we know about trauma is that it literally changes the architecture of the brain. It reduces cortical thickness. And of course, there are vulnerabilities to trauma. Not everybody that goes through a trauma develops post-traumatic stress or certainly psychotic symptoms. But we know that childhood abuse is specifically linked to hallucinations and delusions, which in turn may reflect those traumatic experiences. As we see and as we do those formulations, we can begin to understand how a person's life is really reflected in the symptoms they display. There are 4 types of trauma that we're going to talk about today very briefly: traumatic psychosis, neurodevelopmental psychosis, psychotic PTSD, and psychosis-induced PTSD. So let's start with traumatic psychosis. Childhood trauma leads to underlying beliefs that create a vulnerability to developing psychosis. Okay, and so if we have a child growing up in a home and they get abused as a child, some later trigger may be the instigator to that psychosis. We do know that childhood abuse changes the brain. There are dopaminergic changes, but there are also architectural changes in the brain. Sometimes there's a lack of pruning that occurs during certain developmental periods, which can also be a precursor to that psychosis. There is also that perceived thought that others are going to harm me if you grow up in an abusive home. And these folks are apt to experience more positive than negative symptoms. Certainly, drug use is involved to medicate what they're experiencing. There may be a lot of weight gain or a lot of weight loss, and they may respond poorly to antipsychotic medication. And my guess is that's because the precipitator is the abuse rather than genetic, although in dysfunctional families like that, there's certainly a genetic component. These folks actually are great candidates for CBTp. These folks are more likely to, when addressed for PTSD as well as psychosis, can actually lead to stability, recovery, and the guilt and shame is what you'll want to target when you're working with them. Neurodevelopmental psychosis seems to be more genetically related. So these are folks that have perhaps a pervasive developmental disorder. There may be a little autism spectrum stuff going on, or it may be just a developmental issue. These folks are awkward. They have a hard time communicating. I know I think back in my junior high and high school years, and I remember a classmate or two that looked like this. They were very awkward. They got picked on. They got bullied a lot. And they end up being isolated and are seen as very odd, which is a very isolating thing. These folks, we need to be sure they're getting housing, food, clothing, antipsychotic medication, and some family work, and real gentle cognitive restructuring. Psychotic PTSD is exactly what you think of when we think of PTSD, right? Symptoms of PTSD occur long before the onset of psychotic symptoms. The symptoms are in response to the original trauma. And so these are like voices of the perpetrator, visions of the perpetrator, or ongoing nightmares. And we, especially with psychosis, that abuse may be, they may have had prolonged exposure to that. And so their belief systems, their vulnerabilities are all based in that trauma. This kind of trauma and psychosis responds well to trauma-focused CBTp and trauma-informed therapy like EMDR, and you work on those hot spots that the client presents to you. Psychosis-induced PTSD is just what it sounds like, right? PTSD is triggered by the onset of acute psychosis. And of course, people get very scared. I can't even imagine what I would be feeling if that happened to me. They begin to stop trusting their own senses. They stop their ability. They feel like there's no way that they can interpret reality well. And this is just frightening. So we know that trauma-focused CBT for PTSD integrated with education about understanding what psychosis is and how those two diagnoses blend is very, very helpful. It's important to address their sense of being able to trust themselves, their senses, and the outside world. And so teaching them how to do that is going to be very important. In order to address trauma, we need to ask about it in every assessment. In fact, if we have somebody presenting with psychosis, the first thing that I'm going to do is, along with that intake history, ask about trauma and ask about substance use, because, there's another trifecta that really hangs together. So if a client says, yeah, I've had some abuse, I don't want to talk about it, that's fine. Keep going back and checking though. Don't just say, oh, fine, and leave it at that. Keep going back and press just a little, just gently, to see if they're willing to talk about it as your relationship grows. If they do decide to talk about it, first, agree on a signal between the two of you that your client can give to you when they're overwhelmed. Sometimes a client will say, oh, stop, don't, and you think they're talking about the story rather than asking you to stop. So come up with a signal, take breaks, go slow, and find out if abuse is still occurring. Certainly, we know that folks who have been victimized by trauma tend to get themselves into situations where they continue to be re-victimized even in adulthood. So it's important to assess that. You want to be very engaging, very flexible. You want to be guided by the client's goals. And the two of you really need to develop a shared formulation, right? Go over the stress vulnerability model, offer trauma as a less stigmatized issue than schizophrenia, and certainly address the impact that the psychosis has made, along with the impact that the trauma has made. You remember the making sense formulation. For trauma, what we're going to do is focus, though, on these what happened before and what happened. So predisposing factors and precipitating factors are the things that you're going to want to talk most about in this making sense formulation, because we can only guess what happened before and what were the precipitating factors. They may be two very seemingly far apart stories that are connected by, who knows what. So spend a lot of time here, get a lot of information from your client that will help you to figure out the rest of the grid. The goal here is to reduce distress, to manage the psychotic symptoms as best as possible with all the techniques that you've currently learned, like voice diaries and distraction and focusing. And a lot of grounding strategies are very helpful for trauma clients. There is formal trauma-focused therapy that has been done in research. And what happens is at the very beginning of that research with people with psychosis, right? The first session was psychoeducation about trauma and making a list of feared situations. And then the real treatment begins in session 2. And what they were looking for is, does treatment of trauma exacerbate symptoms? And what they found was that after session 1, kind of a hard session, paranoia and suicidality absolutely reduced. And during and after sessions 2 and 3, there was no exacerbation of paranoia, hallucinations, dissociative feelings, no increased suicidality. There were 8 sessions in all. So it would be interesting to me to see, to check in with those patients years later to see how they're doing. In all, only about 1% showed any exacerbation of symptoms at all. 87% actually continued to have stable symptoms. Severity didn't increase. 11%, almost 12% showed improvements. And only 24 actually dropped out of the treatment. Overall, there were no negative side effects, including adverse events caused by any other comorbidity like anxiety or depression. And there was no re-victimization during the treatment. Mindfulness is another way that we want to address trauma. So with psychosis, you don't want to have long, elongated periods of silence. You want to have a guided imagery. Silence will create space for voices and hallucinations and delusions to begin to bloom. So we want to be talking, not leaving more than 30 seconds of silence at any one time while you're doing this. Be sure that you have some experience with mindfulness, that you understand the underlying concepts of focus and exercising muscles in the brain so that you can control what you attend to rather than being forced to be reactive to the environment. So the goal of mindfulness, of course, is not to change thoughts necessarily or memories, but to have a different relationship with them. It puts it in a whole different ballgame. So those are some of the ways that we can treat trauma very briefly. It's so important also to remember to think about family and friends. If you've got a client with trauma in your office, you can bet there's a family somewhere out there connected to that person who also has trauma too, somewhere going on. And, trauma happens with a lot of folks. Death of a family member, within families. COVID certainly has screwed families up. Good heavens, politics has been traumatic for so many families this last 4 years. And there's certainly enough natural disasters to go around with Nicholas and Ida and fires in the West. This is a frightening time, and more people are experiencing trauma. And so these are just a few things. Be sure to check in with the family and friends if your client is willing to do that, and if the family is willing to. It can go a long way towards healing. Questions?
I have one. I'm wondering, is there any way that we can get those handouts so we can just refer to them, look at them, email to them?
Absolutely. Sandy will email them out. Do you do that, Sandy, regularly anyway?
Yes, we could get those out through an email.
Okay, great.
Yeah, we'll definitely send the PowerPoints out. If there's specific references you're interested in, let us know. We might be able to help facilitate some of that too. Val put together a separate set of like PTSD ones at the back, and depending upon your level of training and interest, one thing or the other may appeal more.
And there's certainly a reference list at the end too that you can explore.
Other questions? Just out of curiosity, how many folks on the screen have been trained in trauma-focused CBT or one of those kind of specific strategies? How many folks have? Okay, a couple. All right. And I've had little bits here and there. So other folks we all have familiarity with trauma-focused stuff. And I guess the other thing, there is a pretty good list at the end of Val's presentation to kind of look at some of those. Is there anyone in particular you'd recommend, Val, for folks if they wanted to dig into it a bit more?
Oh,
or maybe kind of glance through and maybe put in the chat box if there's one or two that you thought are like really.
Yeah, let me see if I can find some references here. I don't know that I would, I have any one thing to dig into. There are so many things,
Gotcha.
so many referenced articles, probably more referenced articles than what I actually included in the PowerPoint. So, and there are PTSD specific references as well as just general. So there's a lot to look through when you get the PowerPoint.